All right, today we are going on a visual journey right inside the body to map out some of the most critical, high-risk conditions you'll see in pregnancy. We're going to trace the why behind the symptoms, that whole chain reaction, so you can really see what's happening, when it really counts. So let's kick things off with a question that every clinician has to answer.
So a pregnant patient comes in with bleeding. Is it painful or is it painless? It sounds simple, right? But the answer sends you down two completely different life or death pathways. And knowing the difference, well, that's everything. Let's break down exactly why.
So here's our game plan. We're going to start with bleeding emergencies, first in early pregnancy, then in late. From there, we'll dive into the big systemic crises like DIC and hypertension. And then we'll finish up with the metabolic challenges and how infections can change everything. So let's get right into it, starting with bleeding in those early weeks.
Okay, Section 1. Early pregnancy bleeding. A little bit of spotting can be totally normal, but it can also be the first warning sign that something is seriously wrong. The real skill is knowing how to tell that quiet whisper from the clap of thunder that's coming.
And that brings us to our first major condition, ectopic pregnancy. Simply put, the fertilized egg has implanted in the wrong spot. Instead of the uterus, which is built to grow and stretch, it's stuck somewhere else, usually the tiny fallopian tube. And that tube is about as ready to expand as a steel pipe. So right away, a clock starts ticking toward a potential rupture and a massive internal bleed.
And this image right here, this pinpoints the danger zone. See the ampulla? That's where it happens most often. The pathophysiology is crystal clear. As that pregnancy tries to grow, it starts stretching the super thin walls of the tube. This is what causes that classic triad of symptoms, a missed period, that abdominal pain, and the dark spotting. If it ruptures, that pain can become incredibly sharp, sometimes even shooting up to the shoulder because the internal bleeding is irritating the diaphragm. Recognizing this pattern isn't just important, it's absolutely non-negotiable.
Okay, now let's jump forward in time to the second half of the pregnancy. Bleeding now signals a whole different kind of problem. We're talking about two major placental emergencies, and telling them apart is one of the most critical skills you can have.
So first up is placenta previa. The problem here is literally location, location, location. The placenta is just in the wrong place. It's attached way too low in the uterus, often right over the cervix, the only exit. It's kind of like a landslide completely blocking the only road out of town.
This visual lays it out for us. You can have a total previa, where the cervix is completely covered, or a marginal one where it's just really close. Now, as the uterus starts to change and prepare for birth, those connections can tear, and that's what causes the bleeding. And here is the absolute most important takeaway. Because that placenta is right there at the exit, a vaginal exam is a huge no-go. You could literally trigger a catastrophic hemorrhage.
Now for the second emergency, abruptio placenta. This one isn't about location, it's about timing. It's a premature separation. The placenta, which is the baby's entire lifeline, is actually ripping away from the wall of the uterus. This tears open blood vessels, which not only causes bleeding, but also starts cutting off the baby's oxygen supply.
And here's where it gets really scary. Sometimes you can see the bleeding, but other times it's a hidden trap. A concealed hemorrhage is so dangerous because you're not seeing the blood loss. But on the inside, the uterus is filling up with blood, becoming rigid and hard as a board and causing constant, agonizing pain.
So let's put it all together. This is the key comparison. For previa, think painless, bright red bleeding, and the uterus feels soft. It's just passive bleeding because of a bad location. For abruption, think pain, painful, dark red bleeding with a rigid, tender uterus. This is an active, traumatic event. Nailing this table isn't just for your exam, it's about making the right call when seconds matter. Okay, so we've gone from localized bleeding to a full-blown, body-wide meltdown. This is disseminated intravascular coagulation, or DIC. It's what happens when the body's entire clotting system just goes completely haywire. It creates this deadly paradox where you're clotting everywhere and bleeding everywhere, all at the same time. This chart here, it maps out the chaos. It all kicks off with some kind of trigger, maybe a severe placental abruption or a bad infection. This trigger unleashes a tsunami of something called tissue factor, and that activates the entire clotting system all at once. Just imagine thousands of tiny little dams suddenly being built all throughout your blood vessels, blocking blood flow and starving your organs of oxygen.
So let's just simplify that whole crazy pathway. Step 1 is massive activation. It's like a fire alarm for clotting, goes off everywhere in the body. Step 2, depletion. The body uses up all of its firefighters, all the platelets and clotting factors, trying to put out all these tiny fires. And then, step 3, hemorrhage. With no resources left, the patient starts bleeding uncontrollably, from IV sites, from incisions, from everywhere. The system has totally crashed.
All right, next up, hypertensive disorders. And this is so much more than just high blood pressure. In pregnancy, it's a sign that the placenta isn't working right. It's actually releasing toxins that poison the mother's blood vessels, causing them to clamp down, get inflamed, and get damaged.
And the most severe form of this is HELP syndrome. The name itself tells you exactly what's going on. H is for hemolysis. Red blood cells are literally getting shredded as they try to squeeze through these damaged vessels. EL is for elevated liver enzymes, a sign that the liver is swelling up and starting to die. And LP is for low platelets, because they're all getting used up trying to patch all the damage in the blood vessels. This is a multi-system organ failure happening in real time.
This table shows you how quickly things can escalate. As preeclampsia gets worse, you can see the damage to the organs happening right here in the numbers. The blood pressure skyrockets. That splitting headache and seeing spots, that's a sign the brain is swelling. Platelets are dropping, liver enzymes are climbing, and the kidney starts to fail, so urine output plummets. It's a cascade of failure, and you have to be able to spot it.
Now, to prevent seizures in these patients, we give them magnesium sulfate. But this stuff is a real double-edged sword. Yes, it calms down the central nervous system, but too much of it can shut the system down completely. So you have to be watching for the warning signs: depressed reflexes, slowed breathing, a drop in urine output. If you see those, you have to move fast with the antidote, calcium gluconate. You know, pregnancy is basically a metabolic marathon. The placenta releases all these hormones that make the mother's body more resistant to her own insulin. This is on purpose. It's to make sure there's plenty of sugar available for the growing baby. But for some women, their pancreas just can't keep up with that extra demand for insulin. And that's when gestational diabetes develops. And this slide right here shows the core of the problem. Think of the placenta as a one-way street for fuel. All the mother's sugar, the glucose, it crosses right over to the baby, but her insulin, it doesn't. So if the mother has high blood sugar, the baby is just flooded with all this extra sugar. What does the baby do? Its little pancreas goes into overdrive, pumping out tons of its own insulin. This excess insulin acts like a growth hormone, creating a really big baby, and it sets them up for a dangerous blood sugar crash the second they're born. Okay, for our final section, we're going to look at a totally different kind of threat: infection. Now, a mother's immune system can handle most things, but there are a few specific bugs that can slip past her defenses and cause serious harm to the developing fetus. We call these the torch infections.
The TORCH acronym is one of those classic mnemonics that really helps you remember these congenital troublemakers. It stands for toxoplasmosis, other infections like syphilis, rubella, cytomegalovirus, and herpes. These are the infections we are always on the lookout for.
So here's a quick, rapid-fire rundown of why these are so bad. Toxoplasmosis, which you can get from raw meat or cat litter, can cause a miscarriage. Rubella is a powerful teratogen, especially early on, causing major defects. CMV can lead to things like permanent hearing loss. And herpes, if it's transmitted during birth, can be catastrophic for a newborn. Each one is a very specific and very serious threat.
So we've walked through these complex pathways. We visualized what's going wrong inside the body, and we really get the why behind the symptoms. But here's a final thought. This deep understanding of pathophysiology, it's not just about passing an exam. It's the foundation that lets us anticipate problems, to explain things clearly, and to offer real comfort. So the question is, how do we take all this science and translate into truly compassionate, patient-centered care? That really is the challenge that connects the science to the art of what we do.